Okay, hi everyone. This is the second talk that I'm doing. This is just going to be lab abnormalities and some disease states that I think people misunderstand. And we'll just work through some problems and discussions and let's start. So let's say we have a patient that has multiple ER visits. They keep coming in with nausea, vomiting, abdominal pain, diffuse abdominal pain. They're starting to develop weakness. They have hyponatremia. So what differentials in the different? What is diseases in your differential? Well, you should all be thinking of acute porphyria. This is one where it's so hard to understand and misunderstood by a lot of physicians in internal medicine. So let's talk about porphyria. So porphyria is defects in the formation of heme, where there's an enzyme defect in the pathway, and there's about 8 or 9 different porphyrias based on there's, which enzyme is deficient. And when you think of porphyria, there's really two main kinds. There's what we call the acute porphyrias or acute hepatic. Those are the ones that present with neurovisceral symptoms, with acute intermittent porphyria being the prototypical. Then the others are the skin ones, where the blistering rash and the acute erythematous rash. We're not going to talk about those today. There's actually 4 acute porphyrias, with AIP being the prototypical. We're going to focus on that, but just for complete sake, there's actually 4, and they're all diagnosed the same way and they're all treated the same way. So that's helpful. So let's talk about AIP, acute intermittent porphyria. What is it? Why do people get it, etc.? What precipitates an attack? So heme metabolism, heme is formed in obviously in the bone marrow. You need heme to form hemoglobin, and then there's also heme formation in the liver, and you need heme for your cytochrome P450 system. So there's always a pool of heme to form your cytochrome P450. Those are the enzymes that metabolize all the toxins in the body, or drugs, etc. So so we're going to focus on that heme. And what happens is in porphyria, in acute intermittent porphyria, there's a defect in PBG deaminase. This step here. So when you form heme, the first step, glycine succinyl CoA, forms ALA. Then you go to PBG, etc., all the way down to forming heme. And again, in AIP, acute intermittent porphyria, here's the defect. And what happens is, because there's a defect, then these two molecules build up because they can't progress through the metabolic pathway. So porphobilinogen and ALA build up in acute intermittent porphyria, and they think ALA is what the molecule that causes most of the neuropathic symptoms. So then you might ask, well, why are some patients symptomatic? What precipitates an attack? It really has to do with ALA synthase. ALA2 synthase, that's in the red cells. So ALA synthase is in the liver. That catalyzes the first step in the pathway. So anything that's going to upregulate ALA synthase in a patient with AIP will precipitate an attack. So ALA synthase will be upregulated when the CYPs, when the cytochromes need more heme. Now, when does that happen? Certain medications like rifampin or something, smoking, alcohol, all of those things will stimulate the cytochrome P450. Starvation will. So that's how a AIP attack occurs, is when it can be infection, it can be decreased nutrition, stimulates ALA synthase, and again, anything that's going to stimulate your cytochrome P450s. So you think about AIP with 2 enzymes. One is that they're deficient in PBG deaminase. By the way, it's autosomal dominant disease. You obviously need that to have the disease, but in order to have an attack, the ALA synthase has to be stimulated. And really, here are your stimulators against drugs. There's a whole long list. Anyone with porphyria, you look on the web for drugs that cannot be used with porphyria. Patients, menses can sometimes precipitate it, because anything that increases progesterone can precipitate an attack, decreased caloric intake, and smoking and alcohol, which can upregulate your cytochrome P450. So then the next question is, well, how do you diagnose it? And so just looking at the pathway, you can see that when ALA synthase is stimulated for the reasons we just talked about, when that happens, and if you're born with this defect in PBG deaminase, so there's a defect here. If this is stimulated, then you're going to form more of ALA and PBG. So hence, that's what you're going to check, PBG being the test. So if you suspect a patient coming in with recurrent abdominal pain, neuropathic symptoms, the best test is a urine porphobilinogen. And that is a really great test. It's 100% specific for one of the acute porphyrias. So if the patient comes in and they have an elevated urine porphobilinogen, you're done. You've actually made the diagnosis of acute porphyria. Most likely it'll be AIP. There are some other tests that can be sent to sort it out. It doesn't matter because it's treated the same way. You can also send ALA. That'll be elevated too. But this is the test. And you would want to do spot, like send it with a creatinine, like a spot urine, because if you do the 24-hour urine, it's just going to delay diagnosis by 24 hours. You don't want to do that. So that's really it in a nutshell. If you suspect it, get that urine porphobilinogen, get the spot test. Now, you can also send a total porphyrin. I see this all the time. People are suspecting porphyria. They send a total porphyrin. That's the wrong test because that can be elevated for a number of reasons, not necessarily AIP. Now, rarely, if you check the labs like 3 days after the attack, the PBG maybe will go back to normal, and the clue might be an elevated total urine porphyrin. So if you're suspecting it, I do recommend checking both urine porphobilinogen and urine total porphyrins. But if you're going to check one of those, definitely check the urine porphobilinogen, because if it's elevated, you're done. You have the diagnosis. If it's not, it's almost certainly not porphyria. But again, that's why you check the total porphyrins. If the total porphyrins are negative and the urine porphobilinogen is negative, then they definitely don't have porphyria, at least as a cause of those acute symptoms, if you're checking it during the acute symptomatic phase. There's some other tests. These are some other tests like total plasma fecal porphyrins. These are good just to sort out the different types of acute porphyria we talked about. There's actually four. There's, hereditary coproporphyria, variegate. But that, don't worry about that. You just want to make the diagnosis of acute porphyria because you can save a life. This is so underdiagnosed. Patients suffer. I think in medicine, we should really focus on diseases, especially that can be treated and are frequently misdiagnosed. Make sure we understand those. We can really make a difference for a patient. So once you consider it, let's say the urine porphobilinogen comes back elevated. Again, you're going to send the spot with a creatinine. You give hematin. Why does hematin work? IV hematin is just heme. So if you give the heme, that'll downregulate the ALA synthase, also known as ALAS1. And because remember, lack of heme or upregulation of the PBG is going to stimulate this. But if plenty of heme is present, it senses that, it's going to downregulate it. There's going to be less molecules flowing through, less formation of your PBG, less formation of your ALA, less symptoms. So a patient comes in with porphyria, you diagnose it, you start them initially on D5, by the way, because glucose can mildly suppress ALA synthase activity, but never the only treatment. Don't just use, you're going to talk to pharmacy, you're going to order your IV hematin, it might not be available to the next day. Typically you give 4 doses, like a dose a day for at least 4 days, stop offending meds, etc. But that's how, and let's say you come in with a patient with established porphyria. What I usually do is I'll check a urine PBG just to correlate symptoms with levels, just to make sure that's the cause. And then you would just start that patient right away on IV hematin. Just out of interest, lead blocks this step here, and that's why lead poisoning leads to, if you have lead poisoning, you block this step, you can have an elevated ALA, and that's why lead poisoning can mimic acute porphyria for that reason. With porphyria, we get the red, brown, purple urine. That's the urine porphobilinogen. If it sits in the urine, it gets oxidized to other compounds and other porphyrins, and that's why you get the colored urine, because PBG itself, ALA, is colorless. It's like when it gets out of the cells, it can turn colors. So how do you prevent chronic or decrease the frequency of attacks? There's a medication that's been around for about 5 or 6 years, givosiran, which is a immunological. It's an antibody, I believe, or it's whatever. it affects the ALAS. It downregulates ALAS, and it can be given monthly. It's a subcutaneous injection once monthly, and can decrease the frequency of AIP attacks. So we talked about this. So again, this is just emphasizing you could send only one test if you're considering acute porphyria, and you could send only one test. You're going to send the spot urine. You're not going to do the 24-hour urine because that's just going to delay diagnosis a day. The spot is just as good. And you would send the urine total porphyrins too, just to completely exclude the diagnosis. But if the urine porphobilinogen is negative at the time of the attack, and if it was collected properly, it almost always excludes acute porphyria. But to be 100% certain, you would get the urine total porphyrins. If that's negative, you're done. If it's elevated, you might retest, or if it's significantly elevated. All right, so that is porphyria. Remember, think about it. Urine porphobilinogen. If anyone is able to make a diagnosis, I'd love to hear about it. Send an email to the course directors. I'd like to hear that you saved a life. Next, we'll talk about anion gap. So mud piles was the old anion gap. Now we have Goldmark, which includes glycols, ethylene propylene glycol, oxoproline. We'll talk about L&D lactate. Remember, L-lactate is the lactate we check on our tests, for lactic acidosis. D-lactate is the enantiomer made by small bowel bacteria. It's a cause of unexplained elevated anion gap. It's not on your basic metabolic profile, so it's a send-out test. We have methanol, salicylates, and then ketoacidosis. What I like about this, it includes the 3 forms of ketoacidosis: alcoholic, DKA, and starvation ketoacidosis. So just to emphasize some points, this patient is very malnourished on therapeutic Tylenol, so not an overdose for back pain, and her anion gap goes up for unknown reason. When you see that, you'll usually check a lactate and a beta-hydroxybutyrate. Those are normal. No ketones, LFTs are normal. So this could be 5-oxoproline, or also known as pyroglutamic acidemia. It's caused, if you're malnourished, and even if you're on therapeutic Tylenol, you can form this anion. It can cause mental status changes, and it's a cause of unexplained elevated anion gap. It's a send-out test, so you'd have to suspect it. Again, it's not the Tylenol overdose where you're going to use NAC. It's therapeutic Tylenol in a malnourished patient. So this is a patient with SBO that has D-lactic acidosis. Remember, L-lactate is the lactate we send, but D-lactate would be a cause of unexplained lactic acidosis. Certain bacteria cause that. If someone has bacterial like malabsorption, and you have a lot of carbs, the carbs can get to the colon where bacteria ferment that to D-lactate just randomly. That can cause encephalopathy. Usually it's patients that have had a previous surgery. Treatment would be an oral antibiotic. So you want to consider it in a confused patient with an unexplained anion gap. In other words, you check the lactate, you check the ketones, there's not renal failure. Why do they have an elevated anion gap? Think about sending the D-lactate level. And this is just talking about lactate. Remember, so lactate is either D-lactate or L-lactate. L-lactate is the enantiomer that we check, in the bloodstream for sepsis, ischemic gut, etc. But L-lactate I think of as type A and type B. Remember, glucose gets converted to pyruvate, and then pyruvate goes, the normal pathway is the top one, where pyruvate goes to acetyl-CoA, then into the Krebs cycle, electron transport chain. You need oxygen, and you form your 36 ATP, right? That's the normal pathway. But if there's any problem with either the Krebs, electron transport, or you don't have oxygen, then pyruvate gets shunted into lactic acid, anaerobic metabolism. The way I think about type A versus type B, if you don't have oxygen, that's type A. If there's a problem with Krebs or electron transport, we call it type B. Whatever it is, the pyruvate has to go this way. So these are just some examples to drive home the point. AZT can poison the electron transport chain in old HIV medicine, and the pyruvate would shunt this direction. This is a patient with metformin. This is the mechanism of lactic acidosis with metformin. Metformin poisons the electron transport chain, so that's how you get lactic acidosis. This is thiamine deficiency. I actually see this not infrequently. Thiamine is needed to take pyruvate to convert it to acetyl-CoA into the Krebs. So thiamine deficiency can cause lactic acidosis because you can't go this way, so you're shunted to anaerobic. Hyperemesis, the patient's very malnourished. Metastatic cancer can do it. I think that's more of just increasing anaerobic metabolism. This is salicylate toxicity. You can use methyl salicylate, and this patient was just using a lot of it, gets absorbed systemically. The classic presentation would be anion gap acidosis and respiratory alkalosis, and the salicylate aspirin will interfere with the electron transport chain. That's the mechanism. Next is cyanide. Cyanide blocks the electron transport chain, and that's why pyruvate is going to be shunted to lactate. All of these are type B lactic acidosis because there's plenty of oxygen. There's not a lack of blood flow. It's not type A, it's type B. Briefly talk about B12. So, we see, check B12 folate levels in the hospital. So B12 is required for two reactions, methylmalonic to succinyl-CoA and also homocysteine to methionine. So if you're B12 deficient, you're going to have both elevated homocysteine and methylmalonic acid. On the other hand, folic acid is only required for this one, not this. So folic acid deficiency will lead to elevated homocysteine. So that can be helpful. Remember, with B12 deficiency, the best test is methylmalonic acid, better than the B12 level itself to make the diagnosis. Just a few cases of B12 deficiency. This is a classic case where B12 deficiency, it affects all cell lines of pancytopenia. You get cell death, you get ineffective erythropoiesis in the bone marrow. The cells can't complete the cycle. And whenever you see an AST greater than ALT ratio, you always think about cell death, whether that's hemolysis, bleeding, pancreatitis, tumor lysis, or rhabdo. And then the other, alcohol can do that too, but this is classic for cell death. This is a hemolytic pattern, except the hemolysis is happening in the bloodstream. And you see an indirect hyperbiliary, total biliary 3.5, indirect 3. In classic indirect hyperbiliary, if it's all from hemolysis or bleeding, the indirect will be at least 70% of the total, which it is here. So we call that the differential of indirect hyperbiliary when the indirect is more than 65-70% of the total. You get hypersegmented polys, you get your macrocytosis. So that's B12. So this one is pernicious anemia, another cause of B12 deficiency. And the way to diagnose, remember, pernicious anemia, autoantibodies against the parietal cells. So you don't make the intrinsic factor. Intrinsic factor isn't present to bind to B12 to get absorbed in the terminal ileum. Best test for pernicious anemia, 3, intrinsic factor antibody, parietal cell antibody, and a serum gastrin. Because of the decreased gastrin or acid production, gastrin goes up. So those are your 3 tests. Remember to check those before you supplement the B12. If you supplement B12 and then check those tests, it can cause a falsely normal test. So just do that. And one other teaching point with pernicious anemia, a lot of times we see B12 deficiency and we just replete without actually diagnosing the cause. With pernicious anemia, there is an increased risk of gastric cancer. So if it's a young patient in their 40s, it'd be nice to know that they actually have pernicious anemia as the cause, because then you might recommend at least one EGD for surveillance. I don't think there's really standardization on that, but there is an increased risk for gastric cancer with pernicious anemia. Next one is a case of Whippets. This is a subacute degeneration of the cord. This is a case where the patient probably had low normal values of B12, and then they're abusing Whippets. Whippets are those nitric oxide canisters that you use for whipped cream. You can buy like 30 per pack. This patient was using 30 a day for a long time and developed neurological symptoms. Posterior cord, so they had lost vibration and position, says it's positive Romberg, and then also the lateral corticospinal tract. And they can improve somewhat with B12 supplementation and stop using Whippets. If you were to do an MRI of the cord, you could see the signal change. Metformin causes B12, just wanted to emphasize that. Crohn's disease can cause it if it affects the terminal ileum. Remember, the intrinsic factor binds to B12 and is absorbed in the terminal ileum, so that's how Crohn's can cause B12 deficiency. This one is dermatitis herpetiformis from celiac disease. Celiac causes small bowel bacterial overgrowth, and you can have multiple vitamin deficiencies. The rash is dermatitis herpetiformis, DH, which is one of the 2 most itchy rashes in medicine, with scabies being the other. So this is celiac. as a cause of B12. All right, anemia. This is a lot on this slide, and this talk is recorded and you can go back, but I wanted you to have a sense of a pretty comprehensive differential of anemia, and we'll go through a few problems. So remember, anemia, it has to be one of three mechanisms. It has to either be a blood loss, hemolysis, or something is wrong with the marrow. The marrow is not working, and the cells are not producing, the precursor cells are not producing red cells. So blood loss is obvious, GI, whatever. Hemolysis, we're going to talk about. And then marrow, I wrote here just the major differential of what's wrong with the marrow. This is a pretty comprehensive list. Nutritional, we think iron, B12, folate, but malnutrition in general, sometimes thiamine, B6 can do it. Decreased erythropoietin, if they're on dialysis, or if they're chronic kidney disease and they're just not making enough erythropoietin, which you need to make red blood cells. Inflammation, and rarely an autoantibody against erythropoietin. Endocrine diseases can cause mild anemia, hypogonadism, hypothyroidism. Sideroblastic anemia is an interesting anemia. That's where there's a defect in hemoglobin synthesis. The way to diagnose that is to see ringed sideroblasts on the bone marrow, which are inclusion bodies. And the peripheral blood correlate of that is what's called Pappenheimer bodies, which you see on the peripheral smear. So what causes sideroblastic anemia? So things that interfere with heme production. So actually, copper deficiency is an interesting one. It can mimic MDS, patients with copper deficiency from a gastric bypass, or maybe they're using, they have poorly fitting dentures. They can't afford new dentures, so they're using zinc, Fixodent cream. Zinc competes with copper, so they're ingesting all that zinc and they get copper deficient. Alcohol, one of the mechanisms of anemia with alcohol use is sideroblastic anemia. And then finally, meds can do it, linezolid. So myelodysplastic is a type of pre-leukemia that also causes ring sideroblasts in a way as a form, the defect in hemoglobin synthesis. So MDS also causes the ring sideroblasts. So that would be in the differential, actually, of sideroblastic anemia. And then there could be a primary bone marrow problem. In other words, something is in the bone marrow preventing cells from being made. And we call that a myelofibrotic anemia. That's the actual name. And we think about something in the marrow that shouldn't be there when we see what's called a leukoerythroblastic smear, which consists on the peripheral sphere of nucleated reds, in other words, very immature reds, immature white cells, myelocytes, and teardrop shells. I'm just going to show you a picture. Myelofibrosis is a cause of that leukoerythroblastic smear. Anything in the marrow. So myelofibrosis would be an autoimmune disease where you're making too much collagen, but it could be prostate cancer, it could be breast cancer, it could be TB, whatever, something in the marrow that shouldn't be there. And you see these early red cells, early white cells, and the teardrop, I imagine the red cells just squeezing through the bone marrow, forming a teardrop shape, also known as a dacryocyte. So when you see the combination of these three, you're thinking, what's in the marrow? And here's an example of that, like a patient with widely metastatic prostate cancer, anemic, and the peripheral smear shows leukoerythroblastic, right? Nucleated reds, myelocytes, and teardrops. They do a bone marrow and it shows diffusely metastatic prostate in the bone marrow, not just lytic lesions or blastic lesions, but actually in the bone marrow itself. We call that a myelofibrotic anemia when the anemia is from a marrow that has something that shouldn't be there. And again, myelofibrosis would do the same thing. So that's what that is. Also, then we talked about MDS and leukemia. Aplastic anemia obviously can cause anemia. That's a misnomer because it affects all three lines. And then something called a pure red cell aplasia, which can be autoimmune. Parvovirus can do that too. It can infect just the RBC precursors. So that would be an infectious cause of pure red cell aplasia. So that's marrow defect. We talked just blood loss. And then finally, there's hemolysis. So I just expanded that slide. Hemolysis, there's different ways to think about it. You can think about extravascular versus intravascular. You can think about congenital or acquired. But when do you think about hemolysis? You think about it when you have a combination, assuming the marrow is working, high retic count, high LDH, high indirect, and a low haptoglobin would suggest hemolysis. Then hemolysis can happen in the spleen or intravascularly. You think about intravascular hemolysis when you have dark urine because the red cells are being lysed in the urine. There can be free hemoglobin in the urine. In other words, you do a dipstick and you see positive heme. And a urine hemosiderin is where the hemoglobin is, all the haptoglobin is used up, so there's a lot of free hemoglobin being filtered at the kidney. That free hemoglobin is being reabsorbed in the tubules, and then like a day or two later it sloughs off and you can stain those cells for iron. So that's a way to diagnose intravascular hemolysis that maybe isn't happening at the time you're evaluating the patient. In terms of the smear, the smear can sometimes help you diagnose the type of hemolysis, spherocytes, warm autoimmune schistocytes for TMA, and if you have RBC agglutination, that could be cold agglutinin disease. That would be a Coombs positive of the complement positive variety, which is the same thing as IgM. So here's some ways, your congenital cause of hemolysis could be, hemoglobinopathy, sickle cell. Membrane would be hereditary serocytosis or enzyme like G6PD. So those are the ones you're born with. And then the acquired would be autoimmune. For instance, warm autoimmune hemolytic anemia is where IgGs coat the red cells, and then when those IgG coated red cells get to the spleen, the macrophages take a bite out of the red cell. Red cell is normally a biconcave disc with a lot of excess membrane. When the macrophage takes a bite out of the cell, then by physics, the red cell forms a spherocyte, and you lose the central pallor. So that's why we see spherocytes with warm autoimmune hemolytic anemia. Remember, if you checked a Coombs test, that would be of the IgG positive variant. Coombs is either IgG or complement. Complement implies IgM. What happens is when they prepare the cells, IgM binds complement, the complement sticks to the cells, but the IgM washes off. So if it's C3 positive Coombs, that's really IgM. It means it's a cold agglutinin. Remember, when IgM binds to red cells, there's 5 binding sites, so red cells can be agglutinated. So when you see agglutination, you're thinking about, and it's a DAT positive C3, that's cold agglutinin disease. That's where those antibodies tend to bind in the cooler parts of the body. Here's some other causes of, I talked about cold agglutinin disease, and let's just do some problems to drive home the point. So patient with neurosyphilis and IV penicillin, and then they present with fatigue on day 11. They're anemic. They have hemolysis, right, because it's indirect hyperbiliary, high LDH, high retic, and low hapto. They do a Coombs test, and it's positive. It's of the IgG type. And then the smear, IgG is usually the warm, which usually you see spherocytes, so you do on the smear. So this would be just warm autoimmune hemolytic anemia from penicillin. Penicillin can induce, Zosyn can induce the hemolytic anemia. It's usually this mechanism. Next case is a patient with a malfunctioning aortic valve. It's a mechanical valve. They also have anemia. They have hemolysis labs because they have indirect hyperbiliary, high LDH, and they have schistocytes. So whenever you see hemolysis plus schistocytes, that's a microangiopathic hemolytic anemia. And in this case, it's from the aortic valve. The red cells are passing through and they're being sheared and forming schistocytes. All right, the next case is presents with dark urine. So this is a case of hemolysis. Dark urine implies intravascular hemolysis, and the acute symptoms, acute onset. Again, the dipstick shows blood. That's the heme. That's the heme molecules from hemolysis being filtered in the urine and being picked up on the dipstick. So this is, they were just started on dapsone. So this is G6PD. This is a patient with G6PD deficiency, and they had a medicine that caused oxidative stress like dapsone. They developed intravascular hemolysis. And there's 3 ways to diagnose G6PD deficiency. One is to check a G6PD level. And that's accurate if you check it when they're not hemolyzing. If they're hemolyzing, sometimes it can be falsely normal because all the healthy cells are left, and those might have relatively normal G6PD activity. So one, again, the G6PD level, best time to check it is when they're not hemolyzing. Next is to look at the smear. You can look and see bite cells and blister cells on the smear. Bite cells are where the hemoglobin is kind of pushed to the side. It looks like there's been a bite taken out of the cell. And finally, you can send a Heinz body test, which is, Heinz bodies are, I think it's denatured hemoglobin, and they are not seen on a regular blood smear. It's a special stain. In my hospital, that's a send-out test. So 3 ways to diagnose G6PD: the level, the smear with the bite cells, and the Heinz bodies. And this clinically fits. You just put them on dapsone, and they're having what looks like acute hemolysis. All right, patient has Budd-Chiari, which is thrombus in the hepatic veins and the IVC. They also have hemolysis with anemia, high LDH, undetectable hapto. Urine hemosiderin is positive, which confirms intravascular hemolysis. And you do a flow cytometry. They don't have CD55 or 59 on their red cells. So this is paroxysmal nocturnal hemoglobinuria. This is an acquired condition of the membrane, the only membrane abnormality in red cells that is acquired as a cause of hemolysis. And so PNH, what happens is they lose these proteins, CD55 and 59, that live on the surface of the red cell. They inhibit complement. Complement's always floating around the bloodstream, binding to things. And without the CD55 and 59 to inhibit the complement will lyse the red cells and you'll get episodic hemolysis, hence the term paroxysmal nocturnal hemoglobinuria. The other association with PNH is having thrombosis in unusual places, not like lower extremity DVT. These patients tend to get Budd-Chiari. So that's what happened here. By the way, any patient with Budd-Chiari, the two diseases you want to think about are PNH and a chronic myeloproliferative disorder like polycythemia vera or essential thrombocytosis. But anyway, in this case, the PNH is the cause of the Budd-Chiari. They also have the hemolysis. The treatment, by the way, for PNH is anti-complement therapy, anti-C5, also known as eculizumab. All right, the next case is a hemolytic process. I think it's just interesting. People are always surprised that the body, you form carbon monoxide. Whenever heme is broken down, we all know heme gets converted to bilirubin, but the intermediate step is biliverdin. For every molecule of heme that's converted to biliverdin, one molecule of carbon monoxide is formed, and then the biliverdin is converted to bilirubin. That's why you have some bruises are purple, biliverdin's green, and yellow bilirubin. But anyway, anytime there's increased blood turnover, you're going to have elevated carbon monoxide from an endogenous process. So a patient with sickle cell, they're chronically hemolyzing. So if you do an ABG on a patient with sickle cell, oftentimes you'll see a CO level of 6-7%. If someone has a retroperitoneal bleed, the next day you do an ABG, you might see an elevated CO. Sometimes it can be a clue that they're bleeding. So important to know. The main other things to think about: smokers get elevated carbon monoxide, and obviously exposure. So just something to be aware of. All right, let's go back to hemolysis. So one of the causes of hemolysis is microangiopathic hemolytic anemia. So whenever you see, and then that'll lead into TMA, thrombotic microangiopathy. Whenever you see hemolysis, you're going to figure out, okay, why? Well, on the smear, if there's schistocytes, then we say this is microangiopathic hemolytic anemia. The cells are being sheared in the bloodstream. And then, so that's MAHA. A case of isolated MAHA would be like an aortic valve, mechanical aortic valve that is non-functioning, and the red cells are just being damaged as they pass through. Now, if you have the combination of MAHA plus thrombocytopenia, then we think about TMA, thrombotic microangiopathy. That's where there's microthrombosis in the small blood vessels, capillaries. And what happens is the platelets are being consumed, hence you get the thrombocytopenia, and that microthrombosis, the red cells, as they pass through, are being injured, and you get schistocytes. So that's TMA. Now, TMA has a differential several diagnoses, but the prototypical TMA is TTP, thrombotic thrombocytopenic purpura, usually autoimmune. So what is TTP? Well, I'm going to go to the next slide to explain that. TTP is a disease against a protein called ADAMTS13. Here's a slide. So this is the lumen of the blood vessel. This is an endothelial cell. And what happens is the endothelial cells secrete von Willebrand factor, and the ADAMTS13 protein will cleave this so they don't form what's called these very large von Willebrand factor proteins, because in the disease state, if you don't have ADAMTS13, these very large von Willebrand factor proteins will extrude into the bloodstream, and they will activate platelets. You'll get microthrombosis. As the red cells are going through, you'll get schistocytes, you'll have consumption of your platelets, and due to the microthrombosis, you'll have ischemia. That's the pathophys. That's why patients are symptomatic. You have microischemia, and TTP, classically neurological symptoms, sometimes stroke. So again, the primary, just remember, TTP is an autoimmune disease, autoantibodies against ADAMTS13, so it doesn't work, or you don't have it. Therefore, these von Willebrand factor proteins are not degraded and cause problems. So I basically stated that here. So the way to diagnose TTP is you check an ADAM TS13 level, and if it's low, that is consistent. If it's less than 10%, and I'm gonna just do a problem. Let's do a problem. So let's say a 32-year-old comes in with confusion. They have some petechiae. They're anemic. They have MAHA, right? So they have hemolysis based on high indirect, high LDH, low haptoglobin, high retic. So they have hemolysis. Then you look at the smear, you see schistocytes. So now we have MAHA because of the hemolysis plus schistocytes, MAHA. Then they have thrombocytopenia. So now it's MAHA plus thrombocytopenia equals TMA. And the most common TMA is autoimmune TTP. They're confused. So clinically, this is consistent. TTP doesn't usually cause renal failure like I was taught in medical school. TTP rarely causes renal failure, usually neurological symptoms. So what are you going to do? You suspect this, you're going to draw some blood. You're going to draw an ADAM TS13 level. You're going to draw an ADAM TS13 and an antibody to ADAM TS13, right? So what do? So then you're going to call your radiology to place a VAS cath, and you're going to start plasma exchange. Why do we do plasma exchange in TTP? Well, several reasons. One, you're going to remove the antibody. So by drawing out the plasma, that's going to remove the anti-ADAM TS13 antibody. It also will remove some of that very large von Willebrand protein. And then the replacement fluid for the plasma remove is going to be the FFP, the fresh frozen plasma. We don't use albumin. We specifically use fresh frozen plasma as the replacement fluid because in that FFP, that contains ADAM TS13. So we're going to replace the ADAM TS13. So in sum, you're going to remove the antibody against ADAM TS13. You're going to remove some of those very large von Willebrand proteins that are a problem, and then you're going to replenish the ADAM TS13. So that's what you're going to do acutely. So if you suspect it, you draw the blood, but you don't wait. You definitely start Plex that same day, and Plex for plasma exchange. And then let's say a few days later, the ADAM TS13 level actually does return low as suspected, 3%. We usually use 10%, usually less than 10% to make the diagnosis. And really confirming, if you see that ADAM TS13 antibody, that basically clinches it. And you establish your diagnosis. You're going to continue daily Plex until the platelet count reaches 150. There's different protocols. Some physicians will continue maybe another 2 Plexes after they each reach 150 is a common protocol. So then what are you going to do long term? Well, you need to decrease that antibody formation just like any autoimmune disease. So you give prednisone. If it's a mild case, you might do 60 of prednisone or 1 mg per kg, but any neurological symptoms, cardiac, or if they're sick, you're going to pulse. You're going to give 1,000 milligrams of methylprednisolone for at least 3 days. That's going to decrease antibody formation, the ADAM TS13 antibody formation. You're also going to give Rituxan typically once a week for 4 weeks. That's also going to decrease antibody formation. Remember, anyone using Rituxan, you want to check your quantiferon goal for history of TB and hepatitis profile to include Hep B core antibody, which might be the only marker that they've had Hep B in the past because you can reactivate Hep B. Anyway, that's an aside. So now there's a new drug out called caplizizumab, which is anti-von Willebrand factor. What that monoclonal antibody does is if it's you inject it, the first dose is IV, then you give it sub-Q, it blocks binding of the von Willebrand factor to platelets, so you can't get that platelet activation. And even though the very large von Willebrand factor monomers are present, they're not binding platelets and not causing thrombosis. So it's standard of care. Anyone that's sick, like with neurological symptoms, should absolutely get caplizizumab as soon as you consider the diagnosis. And then in some centers, it's standard of care in every patient. But the ones where you would absolutely give it would be if they're sick with cardiac neurological manifestations or just sick. And the way they dose that is every day, and one of the protocols is for 30 days after the last Plex therapy, and you just kind of monitor them and decide what to do. One of the side effects is bleeding, right? Because now platelets aren't, it's like a super antiplatelet. It's like super aspirin, Plavix. So that's one of the side effects you can see is bleeding. So yeah, that's TTP in a nutshell. So there are other forms of TMA though. So what is this one? So a patient presents with abdominal pain, bloody diarrhea. also has anemia. They have hemolysis labs, haptoglobin undetected, schistocytes. So in hemolysis, schistocytes, so we're at MAHA plus thrombocytopenia, so we're at TMA. Everyone's always going to think about TTP, even though, again, you typically don't get renal failure with TTP. This is going to be HUS, hemolytic uremic syndrome from Shiga toxin, also known as Shiga toxin HUS. And in this case, a lot of physicians would check the Adam TS13 because you can never be sure, often would put patients on Plex. But in this case, the Adam TS13 returns normal, so it's not TTP. At that point, you're going to stop Plex. Let's say the patient probably wouldn't respond to Plex, the platelets would remain low, and it's just supportive care. So that's on the differential of TTP. All right, here's another case. Patient drinks tonic water. They're coming in with hemolysis, so elevated indirect anemia. I didn't put all the labs, and then schistocytes. So then hemolysis plus schistocytes equals MAHA plus thrombocytopenia equals TMA. This patient, you're always going to think about TTP, so they'll get their Adam TS13 checked. They'll probably be started on Plex, but nothing will happen, and then you'll get that history of the tonic water. So quinine is in tonic water. Quinine can cause an immunologic drug-induced TMA, also known as DITMA. It's just supportive care. You might start with the Plex, but once the Adam TS13 returned normal, you would stop Plex. So quinine, it's kind of scary. It's in tonic water, gin and tonic. Some patients buy over-the-counter quinine tablets for muscle cramps, so you got to ask about it. And this patient could never be on get any quinine again. It would recur. So quinine would be absolutely contraindicated. No more gin and tonic. All right, so this is just a list of all the primary TMA syndromes, and then TMA mimics. I'll start with actually TMA mimics. So when you have that TMA, hemolysis, MAHA, thrombocytopenia, so you make it a TMA, disease states can do that. For instance, HELLP syndrome can do that. Malignant hypertension can cause a TMA-like syndrome. DIC causes a TMA with schistocytes. You'll also have a coagulopathy. And an interesting one is scleroderma renal crisis, where patient has diffuse scleroderma. Let's say they have, positive SCL antibodies, they have sclerodactyly, digital ulcers, and let's say they had asthma, they get put on prednisone. Prednisone is known to precipitate scleroderma renal crisis in patients with scleroderma. They present with like a hypertensive emergency, and they'll have the findings of a TMA on blood smear. In other words, schistocytes, thrombocytopenia, but it's not going to be TTP. It's just from the scleroderma. So these TMA mimics, you're just going to treat the underlying disease. In that case, with scleroderma, with renal failure, you give them an ACE inhibitor, even though they have renal failure, and that can preserve kidney function. But getting back to the primary TMAs, we're going to talk about a complement-mediated case. I just put this here to be complete metabolism and coag. These are incredibly rare. One with B12 metabolism, another one where in the coagulation system, but it's not the classic. It's not like a DVT. It's at the micro level. I put these here just for completeness sake. But these are the four that I focus on with TMA, and also the TMA mimics. Like a patient, by the way, can have lupus. Lupus can cause a TMA type syndrome, and you're not going to give them Plex. You're going to treat the lupus with steroids. Sometimes, I didn't put it here, but antiphospholipid syndrome can sometimes look like a TMA. A particularly catastrophic antiphospholipid syndrome can look like that. And those sometimes you do give Plex. You do Plex sometimes, or IVIG actually, and steroids. Okay, let's do some problems. So this is a patient with hemolysis, with the LDH, elevated indirect. Their schistocytes, so now we're at MAHA plus thrombocytopenia, so it's a TMA, and the team thinks this is the HELLP syndrome, so they deliver the fetus, but the labs do not improve. It's getting worse. They draw Adam TS13, they're not sure. Plex is started, no improvement, and ultimately not getting better. Adam TS13 returns normal. So this is complement-mediated TMA. This is a disease that you're usually born with. It's a congenital defect in one of the complement proteins that inhibit complement activation. So complement can be activated for a number of things, and the body has ways to halt some of that inflammation. I think factor H is one of the proteins that patients can be born deficient in. And for whatever reason, some type of metabolic stress can activate complement, and this can often manifest when the patient is pregnant. There's also an autoimmune variety. It's a difficult diagnosis to make, but the classic example would be a patient just not getting, with renal failure, just not getting better, doesn't have diarrhea, it's not DITMA. But you want to recognize it, because if you're able to give eculizumab quickly, you can preserve kidney function and prevent the patient from going on dialysis. So eculizumab is an anti-complement antibody. Remember, when you give that, you want to, if you can, vaccinate it against encapsulated organisms, particularly Neisseria. So definitely think about complement-mediated TMA and whether you should start eculizumab, but sooner rather than later. All right, eosinophilia. So eosinophilia is defined as an absolute eosinophil count of approximately 300, but hypereosinophilia is defined as an absolute eosinophil count of 1,500 on 2 occasions. If you have that separated by a month, then you, by definition, have hypereosinophilia. Also, you have the syndrome is when you have hypereosinophilia plus evidence of end organ damage. That's what defines hypereosinophilic syndrome. And the differential of that, it can be a primary hypereosinophilic syndrome, in other words, a leukemia causing that, a clonal neoplasm, or more commonly, any cause of hypereosinophilia, no matter what the cause, can cause those eosinophils can cause damage. A classic would be strongyloides causing a Loeffler's myocarditis. So when you think about eosinophilia, big differential. A lot of times it's ignored, but I always look at that. That's like the one differential, like more than anything I look at, rather than like basophil or monocyte. I'm always looking at the eosinophil because a lot of diagnoses are missed. One mnemonic is the NAACP, so N for neoplasm, A for Addison's or adrenal asthma allergies, C for connective tissue disease such as Church-Strauss, also known as now known as eosinophilic granulomatosis with polyangiitis. Parasites can do it, allergic bronchopulmonary aspergillosis, cholesterol emboli, some other disorders. So these are just some examples to run through. So a patient with asthma, now they're coming in with worsening asthma, foot drop, and they have peripheral eosinophilia, and the ANCA is positive. That's a classic presentation of EGPA, poorly controlled asthma. They get a vasculitis. It's ANCA positive. It can affect the lungs. Next one is allergic bronchopulmonary aspergillosis. This is a patient with cystic fibrosis. They have migrating infiltrates. They're not responding to antibiotics despite proper coverage based on the sputum. The clue is they have peripheral eosinophilia. You check an IgE level to make the diagnosis of APBA in a patient with CF. Usually the IgE is greater than 1,000. And then you can, remember, it's not an infection with Aspergillus, it's an immunologic reaction to Aspergillus, but you would treat it usually with Vortier, posaconazole, and steroids. Next is anyone with unexplained eosinophilia should really have a strongyloides. The patient should be evaluated for strongyloides, and the reason is strongyloides, once you acquire it, it doesn't go away. It's one of 2 parasites that can complete the life cycle in the human without an intermediary host. So you get strongyloides by walking barefoot in contaminated soil. It's very common in the Southeast United States, not just overseas. And once you get it, you can have low-grade infection. And definitely some patients have mild non-specific symptoms, a little abdominal pain, a little bit of urticaria, a little things like that. But the reason you don't want to let it go is because if that patient is placed on immunosuppression, let's say they get prednisone for asthma, or in this case a renal transplant, the strongyloides can proliferate and you can get what's called the hyperinfection syndrome, meningitis, sepsis. You could die. So it's good to evaluate for strongy if you don't have another cause. And the best test is usually serology, which is pretty sensitive and specific. And if you diagnose it, usually you would treat it. Ivermectin, it's a daily dose for 2 days, and sometimes up to repeat that in 2 weeks. So, today, tomorrow, and then 2 weeks, repeat that would be the therapy for strongyloides. But it's probably more common than we think. Just you have to look for it. And it can cause like unexplained iron deficiency, things like that. So another case of just adrenal insufficiency can cause eosinophilia. just wanted to emphasize that. That's part of the NAACP. And cholesterol emboli can cause eosinophilia. So a patient has a cardiac cath, and some of the cholesterol migrates to the toes. They get that trash foot, where they have blue toes, but the pulses are intact. It affects the microvessels. They can have livedo reticularis. The clue being the peripheral eosinophilia. It can cause more of a subacute renal failure. So, left heart cath can cause it by contrast, renal failure, but always consider cholesterol emboli. And then I'll just finish up some interesting stuff on coagulopathy. This is the last topic. So just on the differential of an elevated INR, just wanted to emphasize the liver produces vitamin K dependent 2, 7, 9, and 10. The liver also makes factor 5. That's vitamin K independent. You don't need vitamin K. And the one factor that isn't made in the liver is factor 8, which is made in endothelial cells. And we can use that information to help sort out the cause of an elevated INR. So for instance, in liver failure, liver's not working, so your factor 2 and 7 are going to be low. Factor 5 also made in the liver going to be low. Factor 8, no problem because it's not made in the liver. So it's going to be normal or even elevated. Vitamin K deficiency, factor 2 and 7 made in the liver. Liver's working, but the liver can't make the factors because they don't have enough vitamin K. But on the other hand, factor 5 is made independent of vitamin K. So as long as the liver is working, your vitamin K will be normal, no problem with factor 8. And finally, DIC destroys all the factors, so low levels. So you can use that information to help you diagnose the cause of an elevated INR. So Tylenol poisoning with an elevated INR, you're going to think liver dysfunction. So 2 and 7 are low, but 5 is also made in the liver. Has nothing to do with vitamin K. That's also going to be low. Factor 8 is made in endothelial cells, so that'll be normal or elevated. So this would be the profile of liver failure. Severe malnutrition, this is where they have vitamin K deficiency. So factor 2 and 7 are vitamin K dependent, made in the liver. Those will be low. But factor 5, the liver's working, so there won't be a problem. So this is the classic profile with vitamin K deficiency. And finally, DIC, everything's going to be destroyed. So factor 8 in particular is helpful, like if your patient's in the ICU post-liver transplant or severe liver disease, like is that elevated INR, is it from the liver not working or are they in DIC? Factor 8 can help you sort that out in particular. That is the end of the talk, and good luck with everyone. And if anyone has questions, you can always email the course directors. I'd be happy to answer. Hope this is helpful. Hope you make a few diagnoses based on the talk. And good luck with everybody. Take care. Bye-bye.